Today, we're going to talk about the drunk patient. When a patient smells like booze and is acting a fool, it is easy to put them in a box and early anchor on alcohol intoxication as a diagnosis. These patients can be especially challenging. They can be aggressive towards you and your staff. Your staff may not care for them the same way that they care for other patients because maybe the patient's rude, disheveled, or smells bad. No matter how hard the situation gets, it's your job to be an advocate for the patient. So let's go ahead and get started. Approaching an intoxicated patient should be no different than approaching any other patient. Start with a critical differential diagnosis. So our critical differential for this patient would include blunt head trauma with intracranial hemorrhage. Next up on the list is meningitis, maybe the patient has an electrolyte abnormality such as hypoglycemia. Maybe the patient has an infection like a pneumonia or UTI, and that's what's causing them to be altered. And finally, maybe the patient is intoxicated with something else and is actually presenting with a different toxidrome. Having a strong differential diagnosis will allow you to pick up potentially life-threatening conditions that are confounded by the intoxicated state of the patient. The critical differential will also guide your H&P. You will make sure to actually really assess the skull and make sure there aren't signs of any trauma. You will be sure to check the vital signs to ensure the patient isn't febrile and that the patient doesn't have neck stiffness. You'll check a blood glucose level. You'll do a skin exam to make sure the patient doesn't have cellulitis and that there are no signs of any other infection. You'll be sure to perform a tox handshake where you look at the patient in the eyes and feel their armpit to see if there are any signs of other toxidromes. You don't want to put the patient in the drunk tank only to find out hours later that he was hit by a car. That would be an automatic ticket to the M&M show. So now that you've gone through a thorough history and physical, the next question is, do you need to order labs? The answer to that is no. If you were able to rule out all of the diagnoses on your critical differential via history and physical exam, then you don't need to order any labs. But if on your history and physical you pick up something that looks like an infection, then yeah, you would want to order labs. The next question is, what about an alcohol level? In general, it's not necessary to order an alcohol level. If the patient is obviously intoxicated, you don't need a number to make you feel better that he or she is intoxicated. If there's any doubt that the patient has alcohol intoxication, then sure, you can consider getting an alcohol level. If the level comes back 0, then you know you need to go fishing for another cause for the patient's altered mental status. So you've ruled out something bad. Now what? Can you just discharge the patient home? Well, technically you can't discharge a patient until they are sober. Clinical sobriety is determined by a patient's ability to walk, answer questions appropriately, and appear in general to be sober. You don't need to wait until the blood alcohol level is 0. As you'll remember, chronic alcoholics may have GABA receptor modulation, and as a result, they will be clinically sober even when their alcohol level is above 0. For these patients, they'll start to withdraw if you wait for their alcohol level to go to 0. So your golden ticket to discharge this patient is to get them clinically sober. So how long do you have to obs them? In order to figure this out, you'll have to understand the metabolism of alcohol and how fast it takes for alcohol to clear the system. So let's go ahead and draw this out. In general, alcohol is cleared at a 0 order rate, which means nothing you do will cause a person to sober faster. Although it is difficult to study the rate of metabolism, it is believed to be around 25 milligrams per deciliter per hour. You can give the patient all the caffeine or IV fluids in the world, but it will not cause the alcohol to clear faster. So with that knowledge, let's go over the intoxication profile of a patient, understanding that everyone is different and can feel differently at different levels of alcohol. So this is just kind of a rough table. Let's start by writing in the numbers for blood alcohol levels. We have 0, 100, 200, 300, and 400. At 100, the person may be buzzed. 200, they could be drunk. At 300, they'll probably be hammered. And finally, at 400, they'll be in a coma. For reference, I'll put 80 over here, 0.08, which is the legal limit for some states. So the nice thing about this table is we know that it'll take about 4 hours for a person to have a measurable improvement in their mental status. This is because, as we said, alcohol clears at 25 per hour, and as a result, it'll take 4 hours to go from 300 to 200. So in this case, hopefully the patient has gone from being hammered to now just drunk. And remember what we talked about, chronic alcoholics will have GABA receptor modulations. So each of these mental status changes will occur at higher blood alcohol levels. I've drawn black arrows to represent this. So at 200, the chronic alcoholic may just be buzzed. At 300, they could be drunk. And at 400, they could be hammered. Again, it's important to be a steward for your patient. If they are intoxicated and elope from the ED and get hit by a car, you are responsible for the patient's injuries. If the patient is starting to become agitated, you may need to sedate him or her until they are clinically sober. Always take control of the situation before it's too late. And with all that said, you should now have a good framework to work with when you see an intoxicated patient. Thanks for watching.